Okay. Hi, everybody. I'm Dr. Chris Richardson. I have a family practice down in Gravenhurst, as well as working at the Bracebridge Hospital doing anesthesia. As I think all of you know, my talk today is going to be about medical assistance in dying. This is meant to be a fireside chat, so feel free to interrupt or put up a hand and ask questions, and I'll try to address them as we go. There will be a chance to ask questions afterwards as well. Okay, so medical assistance in dying, the short form is MAID. I'm going to give you my perspective on that, and we'll talk a little bit about the data, about how common it is, about how you access it, and about what it actually entails. If I cannot give consent to my own death, whose body is this? Who owns my life? This is a quote from Sue Rodriguez, who had ALS, or Lou Gehrig's disease, which is a disease of progressive muscle weakness that eventually leads to paralysis, including paralysis of the muscles of swallowing, speaking, and breathing. In 1993, she sought the right to have an assisted death. The laws legalizing MAID in Canada came about as a result of challenges made in court, stating that banning MAID violated the Charter rights and freedoms. The first challenge there was Sue Rodriguez in 1993, and she lost her appeal 5-4. The court agreed that banning medically assisted death did infringe on her rights, but they argued that it was justified to protect vulnerable people. Rodriguez went on to die in February 1994 with the help of an anonymous physician in what was technically a criminal act, but it was a criminal act that Canada chose not to prosecute. It came up again in 2015 in the Carter decision, which led to MAID becoming broadly legal in Canada in 2016. It was brought by Gloria Taylor, who also had ALS, and by Kay Carter, who had spinal stenosis, which is a disorder of degradation of the spinal column that leads to chronic severe back pain and weakness in the legs. In this case, the court ruled 9-0 that an absolute ban on assisted dying was too broad, and it gave Parliament 12 months to come up with a law to accommodate it. Right off the bat, C14 was criticized as being too restrictive because it required a reasonably foreseeable death, which was not part of the original court decision. So MAID became legal in 2016 under the Bill C14, and it was expanded again in 2021 following the Truchon decision. So Jean Truchon had cerebral palsy, and Nicole Gladue had post-polio syndrome. Neither of them was dying imminently. Their case was heard in the Quebec Superior Court, and a judge ruled that the reasonably foreseeable requirement violated their charter rights. Rather than appeal, the federal government chose to introduce Bill C7 instead. In this case, it wasn't the Supreme Court, it was the Quebec Superior Court that led the government to act. So let's look at a patient story. Margaret is 71 years old, a retired school teacher in Bracebridge. She was diagnosed with advanced lung cancer 8 months ago. Her oncologist has told her that treatment is no longer working. Margaret loves her cottage on Lake Muskoka and her 3 grandchildren. She is sharp, funny, and clear-eyed about what is coming. What she fears most is not death itself. It is losing herself before she gets there. I don't want my last memory to be of the ceiling of a hospital room. I want it to be the lake. As we look at some of the numbers now, keep Margaret in mind. Behind every statistic on the next few slides is someone like her. In 2024, 16,500 Canadians received a medically assisted death. That's the most recent year that we have data available for. This works out to be 5.1% of all deaths in Canada, so about 1 in 20. Margaret is one of those people whose numbers these numbers represent. Initially the rapid growth of MAID in Canada was a subject of a lot of criticism. However, that growth has slowed dramatically. From 2010 2019 to 2020, the growth rate was 36.8%, but by 2023 to 2024, it was 6.9%. So the thinking is that we're sort of reaching a natural, stable level. As of the end of 2024, 76,475 Canadians have received MAID in total across the country. In terms of who receives a medically assisted death, the average age of patients is 78, with the vast majority of them being over 65. As you can see in that second point on the slide, the most common underlying condition is cancer. But note that the total there is more than 100% because patients can, of course, have more than one underlying cause. The vast majority of these patients were already in the process of dying from their disease. However, 4.4% of patients had a diagnosis that didn't make their death reasonably foreseeable. Most of these patients had neurological conditions or other conditions such as diabetes, frailty, chronic pain, or autoimmune disorders. 74% of patients who received MAID were receiving palliative care before they received MAID, so access wasn't an issue for them. This slide shows the reasons patients gave for requesting MAID. Each patient can choose more than one, so again, the total adds up to much more than 100%. The text is pretty small there, but it's interesting to note that the top reasons people gave for requesting MAID is not about physical pain. They're about the loss of meaningful activity, loss of ability to do daily tasks, and loss of dignity. People are not choosing MAID because they hurt too much. They're choosing it because they can no longer live in a way that makes life meaningful to them. This is definitely consistent with my own experience across the provisions that I've been involved with. In terms of where MAID is provided, most people choose to die at home surrounded by their family in a place that they love. This was the case for our patient Margaret that we discussed earlier. It's interesting to note that that little 2% slice there of other locations. I have one colleague who provided MAID to an inmate in a federal prison. And one common option that I hear about, although I haven't seen it locally, initially sounds a bit morbid, and I guess it is, but one of those other locations is to have their medically assisted death in a funeral home. And at first that sounds kind of startling, but really it's very practical, but also the funeral directors are experts in helping people through bereavement. So if you think about it, it actually does make a lot of sense. One of my medical school classmates provides MAID in the Ottawa Valley, where she has to get much more creative about where to provide. She has provided MAID in her own backyard, and in one case, even in a hotel room. The access to MAID varies significantly across the province, depending on where you live. Some publicly funded hospitals and hospices, particularly those with religious affiliations, do not permit MAID on their premises. This can lead to forced transfers where frail, vulnerable patients near the end of life have to be moved from the facility where they are receiving care. This is a significant access issue that I feel very strongly about. I feel patients should not be denied legal medical services in a publicly funded setting. That said, we are very lucky here in South Muskoka, and in North Muskoka as it happens. Muskoka Algonquin Healthcare are our local hospitals, and the Andy's House Hospice in South Muskoka here in Port Carling, as well as the home care services, are all very supportive of MAID. So this means that South Muskoka residents can access MAID in the hospital, in the home, or in the hospice. In terms of what makes somebody eligible, there's not a lot of criteria there. There's really a list of just 5. They have to be confirmed by 2 assessors, and the first 2 are very straightforward. You have to be eligible for government-funded health services in Canada. And this point is here just because Canada doesn't want to intend to become a medical tourism destination for MAID. So you need to have access to healthcare in Canada in order to receive it. At this point, you have to be over the age of 18, and you have to be capable of making medical decisions. In this context, capable means that at the time of making their request, the person understands the nature of their medical condition, the proposed procedure and its consequences, and the alternatives available to them. And they can appreciate how this information applies to their own situation and communicate a decision about it. In the MAID context specifically, capacity is assessed at the time of the 2 physician assessments and at the time that MAID is provided. Capacity isn't a set point, it can fluctuate. Someone may be capable in the morning, but not in the afternoon. And capacity is decision-specific and time-specific, not a permanent status, so it definitely can change with time. The next criteria is that you have to have what the courts have called a grievous and irremediable medical condition. That means that you have to have a serious illness, disease, or disability, be in an advanced state of irreversible decline in capability, and you have to be suffering from physical or psychological, you have to be experiencing physical or psychological suffering that is intolerable and that cannot be relieved under conditions that you find acceptable. The last criteria is that we have to, of course, verify that the request is voluntary. Nobody wants to think about people having MAID because somebody's coercing or pushing them to do it. I've alluded a couple of times here to this idea of natural death being reasonably foreseeable. When we assess this, no specific prognosis is required, like you don't have to be within the last 3 months or 6 months of your life. Reasonably foreseeable really just means reasonably predictable. So that means death is expected in the not too distant future, and or the illness puts them on a path toward death that is predictable. When discussing MAID, we talk about track 1 and track 2. These are the two pathways through which a patient can be eligible to receive MAID, and the rules are slightly different for each. Track 1 is the more straightforward path where the patient has an illness moving towards death. Example would be cancer no longer responding to treatment, or advanced heart failure, or end-stage COPD. We don't need a specific prognosis in weeks or months. We just need to say this person's death is on a predictable trajectory. Track 2 is for patients who are suffering from a serious condition that's causing intolerable suffering, but they're not dying from it. They may go on to live for years if they didn't have MAID. There are additional safeguards that have been added because they are not on that predictable path. One is that there's a 90-day assessment period, and that's just a minimum of how long it can take to be assessed for track 2. And the second is that we must consult with a specialist who has expertise in the condition that is causing the suffering, unless one of the assessors already has that expertise. So let's look at another patient story. Robert is a 68-year-old retired engineer with ALS. He was diagnosed with ALS 14 months ago. He's still mentally sharp, but he knows his body is failing steadily. He can still speak, swallow, and sign his name. He doesn't know how much longer that will last. Robert knows that he wants MAID, but he's worried. What if he waits too long and loses the ability to consent? What if he feels he has to choose to die earlier than he wants to? I just want to know that there's a door I can open when I'm ready, even if I never open it. Robert's story introduces a different kind of fear from Margaret's. Margaret feared losing herself before she died, but Robert fears being trapped or having to choose MAID earlier than he wants to, just to guarantee he can still consent when the time comes. That's a pretty common dilemma for patients. Many would like to have MAID the day after they can no longer consent. He's not asking for MAID today, he's asking will he still be able to access it when he's ready? The next slide answers that question. The waiver for final consent gives patients the ability to waive the requirement for consent immediately before MAID. It's only available to track 1 patients, and it's an agreement completed between the patient and a specific provider. MAID can proceed on or before the selected date if the patient loses the ability to consent. It's only been invoked in about 785 of the 16,500 cases in 2024, or about 5% of cases. And I think of it as a bit of an insurance policy. So this is what Robert needs. The waiver means he can choose the date he wants to die, but if he lost the ability to consent on or before that day, the plan could still proceed. To be clear about what on or before means, if Robert loses capacity before his chosen date, say he has a sudden decline, MAID can proceed at that point rather than waiting.
Can I ask a question?
Sure.
What if he's doing better than he thought he was? Can the date get pushed?
Oh, yes, absolutely, yes. So the patient can change their mind or push the date at any point. They have the ability to withdraw their consent without penalty, meaning that it doesn't nullify their existing assessments or anything. right up until the time the drugs start to go in. After that point, it's a one-way street. But up until then, yes, they can push the date anytime. This idea of having an insurance policy really resonates with patients. It gives them the comfort knowing that if they do lose capacity, they can still have MAID. I had experience with a patient myself in the days before the waiver for final consent was available, for a patient who had lung cancer that had spread to the space between his lungs and was gradually expanding. He didn't want to give up any of his time with his family, so he was very late in setting the date. And on the day before he was supposed to receive MAID, he took his medication that's used to help with his breathlessness, and it caused him to get confused. And that really terrified him, because he knew if he was confused at the time I came to provide MAID, he wouldn't be able to receive it. So what he chose to do instead was he just didn't take any of his medications up until the time that I came. And that meant that he spent the last day on this earth feeling like he was suffocating, sitting at his table. So I was really pleased to see this waiver option come along, because that's something he really could have used. When I came to provide his MAID for him, he was so short of breath he couldn't lie down to receive it. This is the broad shape of how MAID provision actually unfolds. There's a few things worth highlighting. All MAID services are fully funded by OHIP, so there's no cost involved. The number one milestone at the start of the process is to write a written request, and there's a specific form that we call Clinician Aid A for that. A doctor or a MAID coordinator can help somebody access that. 2 practitioners must confirm their eligibility. Usually one of those 2 will be the provider on the day of, and those can be an MD or a nurse practitioner. On the day of MAID itself, the patient and the provider agree on the date of MAID, but as we were talking about before, it's not set in stone. It can always be changed. The patient and the provider, on the day itself, a home care nurse arrives and 2 IVs are put in. We use 2 just to be sure, in case one of them fails, we have a backup. By the time that I arrive, I confirm that, of course, that the patient still wants to proceed. I draw up and prepare the medications. And then when both the patient and I are ready, I administer the medications. And I'll give you a bit more details on the medications and how that goes later. But the whole process really takes about an hour. After death is declared, the home care nurses or a family member contact the funeral home, exactly as they would for any expected death in the home. People often ask if there's a mandatory waiting period between the time that you request MAID and when you can receive it. And since 2021, there hasn't been. In theory, a track 1 patient who has a reasonably foreseeable death could request MAID and receive it on the same day. In practice, though, the logistics of arranging the assessors, ordering the medications, coordinating around home care means it can take at least several days. It'd be hard to do it any faster than that. About a quarter of patients who request MAID don't ever receive it. Most of those patients die before they receive it. They may have decided not to choose a date, or they may have chosen a date but died before they got there. In my experience, being approved for MAID brings an enormous feeling of comfort for patients, and even if they decide not to act on it. So those who withdrew may have found that palliative care was sufficient, and they would continue with palliative care until they have a natural death. Most people who do get to the point of having formal assessments do qualify for MAID. Only about 6% are deemed ineligible. A common scenario is that somebody requests MAID earlier in the course of their illness, and they don't yet meet the criteria, but we know that their illness is going to progress. And if that's the case, rather than saying that they don't meet the criteria, we leave the assessment open and keep in touch. And when their symptoms progress and they meet the criteria, then the process can proceed. We have options for both patient and clinician-administered MAID. So clinician-administered is where the provider administers the IV medications directly. It's very fast and reliable, and it's used in the vast majority of cases. But there is the option for patient-administered as well, where the patient is given a prescription for oral medications that they can take at a time and place of their choosing, giving them full control. The challenge there, though, is that there is a much slower onset, and there's a small risk of incomplete absorption if you're taking the medication by mouth. Every year, it's only used a handful of times in Canada, and in fact, in 2024, all cases of MAID were done by an IV provision. For an interesting perspective on patient-administered MAID, though, there's a great movie on Netflix called Paddleton. I don't know if anybody's seen it, starring Ray Romano, where two friends have exactly this process in Oregon, where self-administration is the only legal option. So medically assisted death is available in 14 of the US states, but all 14 of them require self-administration. So we have a unique system up here allowing physician-administered. Okay, we've covered a bit on how the process works. So I'm going to introduce a common difficult question that we're asked. So let's look at another patient story. So Eleanor is a 79-year-old retired nurse who has early dementia. She was diagnosed 18 months ago. She is still largely herself. She drives, cooks, reads, but she's watched her mother disappear into dementia over 7 years, and she's terrified of that path. Eleanor's daughter asked at the appointment, "Can Mom apply for MAID now before it's too late?" This is a very common and complex question. I know who I am right now. I want someone to listen to me while I can still say it. Eleanor's story is one that generates lots of questions and emotions. She's still largely herself, and she's not imminently dying. Her daughter's question, "Can Mom apply for MAID now before it's too late?" is a very common question that we'll address in the next slide. So MAID for dementia, such as Alzheimer's and other related conditions, can be done if they meet all of the eligibility criteria. There is often a window where patients' function has declined, the suffering is intolerable, yet they still have the capacity to make a decision where they can meet those eligibility criteria. That window may be wide, narrow, or it may never open. There are no guarantees. Capacity will ultimately be lost as the disease progresses, and acting early does not ensure access. In 2024, 368 patients with dementia did receive MAID, but only 106 of those had it listed as the only condition. On the day of MAID, family and friends may be present for the procedure. I have had one case where the patient didn't want any of their friends or family there, and it was just me and the nurse who were there. But I've also been to them where I've arrived at a condo where there's kids and grandkids and great-grandkids, and there's a whole party going on. I went to a house once where they just finished having lobster and Dom Perignon. The patient themselves couldn't eat it, but they could taste it and spit it back out. So, I have certainly been there where there's been a real festive atmosphere. And in a lot of cases, the patients are ready and they're excited and they're happy and they know they've had a chance to say their goodbyes and they're ready to go. So one of the technical things I do when I arrive is make sure that those IVs are working well, because we don't want any failures. The patient is given one final chance to withdraw their consent immediately before the drugs are given. And then there are 4 medications that are given. It's worth noting that these 4 medications are exactly the same medications you would receive if you were having a general anesthetic for surgery in the hospital. The doses are about 4 to 5 times higher, though. The first medication that we give is called midazolam, which is very similar to Valium or lorazepam Ativan, which people might be familiar with, except it's given through the IV, so it works quite quickly, and it causes relaxation or eases anxiety. The second medication, lidocaine, is just some freezing to numb the vein, because the third medication can sting. The third medication consists of 2 very big syringes, and it takes a couple of minutes to give those. As it's being given, the patient falls asleep and then into a deep general anesthesia, and then they continue to get even deeper unconscious to the point where brain activity has more or less completely stopped. The fourth medication, rocuronium, there is a muscle relaxant, so it relaxes all the muscles in the body, including the muscle of breathing. As this happens, blood pressure drops, oxygen levels start to drop, the heart slows and stops. My practice is to give the 4 medications and then to set a timer and sit quietly for 5 minutes. And during those 5 minutes, sometimes it's very quiet and somber, and sometimes patients' families tell stories, talk about their loved one who's passing. After the 5 minutes, I listen to the chest for a full minute to confirm that heart sounds have stopped. and then declare that the patient has died. After death, the funeral home is contacted in the usual way. And then sometime in the next few days, an advanced practice nurse from the coroner's office will typically call a family member. And this is just a quality control and an opportunity for the coroner's office to make sure there were no concerns that the family had and answer any questions. One important detail I think that some people are happy to hear about is that before I leave the house, I complete the death certificate. And the death certificate, the cause of death on the death certificate is not medically assisted death. It's the condition that led to the request for medically assisted death. So there's nothing on the death certificate to indicate that it was a MAID death. And that can be important for things like life insurance. And the law is pretty clear in Canada that life insurance can't be denied because somebody's had a medically assisted death. In terms of where things stand on expanding MAID, there are sort of 3 areas that are active. The first is on advanced requests, which is not yet permitted in Ontario. They are permitted in Quebec since 2023, and there is federal legislation under review, but it doesn't exist yet, and I haven't seen the final form yet. For mental illness as the sole condition, that has currently been excluded. There was a sunset clause introduced in 2021, giving government 2 years to do it. That was then extended and has since been extended again, and it's currently extended until March of 2027. It's an extremely complicated thing to implement. So there's some work underway on that, and we'll see if it comes to fruition. Mature minors means people under the age of 18 who are mature enough to have capacity to make the decision, and that's not currently legal, but there is some work being done there as well. In terms of why I do this work, I feel very strongly that patients should have access to a medically assisted death. Giving patients control over when and how they die can bring dignity, peace, and comfort. It's sometimes emotionally draining to be involved in it, but it is frequently very rewarding. Patients and families almost always express deep gratitude for my involvement, and I, in turn, am very grateful to get to know some remarkable people at the end of their lives and to help them die in the way that they choose. Here's some resources regarding a medically assisted death. The first 2 organizations there, Dying with Dignity and Bridge C14, are excellent. They have a lot of resources for family members or for children or for other people who are involved with the patient who requested MAID, and of course, resources for them as well to help support them. There have been a number of books that have been written about it. That first one in particular, This is Assisted Dying, is a wonderful book that I've read, and the other 2 are meant to be quite good as well. There is a MAID care coordination service at the provincial level that anybody can connect with through a 1-800 number 24 hours a day, 7 days a week. I suspect that these coordinators often are answering a lot of questions and people who are just wanting to understand what their options are. But they can also make effective referrals onto physicians and nurse practitioners to connect patients. So even if somebody has a physician or doesn't have a family doctor, or their family doctor doesn't consent to be involved, they can access that. We do have a home care coordinator who's dedicated solely to coordinating medically assisted death in Simcoe, Muskoka as well, and that's her contact information there. And that's it. Does anybody have any questions? Yeah.
Is there a handout for this presentation?
There isn't, but it is going to be online. Yeah, Paula,
There'll be on the recording. You'll see the slides as well, so you can stop and.
Yeah. Yeah.
Remember to repeat the question.
Oh yes, sorry. Yes, yeah. Yeah, at the back there.
I'm sorry, but if this is a very emotional thing, and when one connects with a person that's going to assess you, it seems to me one has to feel an emotional connection to that person. And I'm sure all of you in this situation delivering this are very lovely people, and one develops that connection. But if that connection is not there, can you choose another practitioner?
Yeah. So what she's asking is if there isn't a strong connection between the patient and the assessor, if that connection doesn't seem to be there, can you ask for a new or different assessor? I haven't actually heard of that happening. I think most people who are involved with this work are in it because they believe strongly in it, and they are there to help people in a difficult time. But absolutely, there's nothing preventing you from doing that. There's no limit to the number of medically assisted death assessments you can have. Within our community, there's not that many people doing it, so there's a bit of a limitation there. But the care coordinators, when they need to, will bring in assessors from Aurelia, or Huntsville assessors do come down to Bracebridge occasionally too.
Is it one visit or two with this assessor?
Yeah, no, that's a good question. She's asking if it would be a single visit or if it'll be a couple of visits. And the answer is that it varies considerably depending on the scenario. So I would say that 2 visits is fairly common. In some cases where a patient is desperately suffering and keen to go ahead as soon as possible, it can sometimes be a single assessment by each of the assessors. Of course, there's the 2 assessors. So what in an urgent situation, the person who's going to be the provider who's going to be providing MAID may not meet the patient until the day of, but that's relatively less common, I would say. Yeah. On the other hand, sometimes I get referred a patient who's early in their cancer journey. They may know that it's already incurable, but they might not yet meet the criteria. And sometimes it's months or even years that we're just touching base occasionally to make sure that that we're both on the same page and know where they're at, and so that when they are ready, that the service is accessible to them. Yeah. For the track 2 patients who aren't dying, who aren't dying from a natural death already, but do meet all the other criteria, I would think it's typical to have multiple visits, and those track 2 assessments are extremely complicated. We need to make sure that all the possible treatments have been considered, and I would say in that case, it's usually multiple visits. Yeah. Any other questions?
With track 2 clients that are in a vegetative state, for example, the terminal illness, can anything be done under those circumstances?
So track 2 refers to somebody who's not death isn't reasonably foreseeable.
That's correct.
Yeah. So for those people, no. There's if you're on track 2, you can't waive that final consent. So the patient has to be able to consent at the end on track 2.
So even if they're in a vegetative state and virtually non-communicative, but yet death is not evident in the foreseeable future, they have no course.
Yeah. Sorry, I'll repeat the question there. So if a patient is in a vegetative state but not dying, and they meet the criteria under track 2, is there any way for them to proceed with MAID? And it's the short answer is no. If they're on track 2, then they have to be able to consent at the end. In reality, though, if somebody's in a vegetative state, it's not common to be in a vegetative state without also being on a track toward death. If you're being, it's not out of the question, but it's a relatively uncommon scenario. In every case, the request for MAID has to come from a patient who has decided that they want it, and they need to have met all of those criteria at some point. So for them to request it, are you thinking like an ALS patient, for example, or yeah? So in a patient with ALS, they are all track 1 patients. Everyone with ALS will die from ALS. It is a progressive illness that just gets worse and worse, even with all kinds of life support. Death is considered to be inevitable with time. So people with ALS generally do have good access to medically assisted death. Because ALS doesn't affect somebody's ability to think or make decisions. So the communication piece can be challenging if they waited until later in their illness where they're not able to speak. But there can be means of communicating to confirm that that they do meet the criteria and they're capable of making the decision.
Thank you.
Yeah. And another interesting point with ALS is, it's an awful, terrible illness, but it affects only the nervous system. The rest of the body is unaffected. So this can, it's a bit of an unusual thing to think about. But one silver lining sometimes for patients is that a patient with ALS can choose to do organ donation, and in this case, especially if it's one of those awful situations where it's striking down someone who's young and healthy, otherwise. These are they can go on to save the lives of multiple other patients as well, which I think can bring meaning to the death of the person who's experiencing that. Yeah.
So if we take that one step further away from ALS, it's a massive head trauma.
Hmm.
An individual who's caught up in some sort of accident.
Yeah. So
Recovery is not likely.
right. So for somebody who's had massive head trauma, those people, generally speaking, are not going to be able to consent to MAID. So unless it was an unusual circumstance where they had already met the criteria for some other reason, for example, somebody who had cancer and they're very frail and they fell and hit their head and had head trauma that way, if they've already met the criteria and waived the requirement for consent, they could proceed. But that's really the only circumstance where that would happen. Yeah. In those kind of situations, it does draw a bit of attention to the importance of advanced care planning and making sure your family knows what your wishes would be if you ever end up in that situation. Because if someone has massive head trauma, they almost certainly will die unless we do things to keep them alive. So if prognosis looks terrible, I think most of us would choose to have palliative care and be kept comfortable and allowed to die if there's no hope of a meaningful recovery. So it's important to have those difficult discussions with families, with your power of attorney or your family members who would be making those decisions if you can't, so they know what it is that you would want in that circumstance. Some people want to be kept alive at all costs, but I don't think that's most of us. I think exactly right. Yeah. Yeah, so and a DNR refers specifically to when somebody, their heart is stopped or not beating effectively, or they're not able to breathe, and putting in breathing tubes, chest compression, shocking the heart. But in some cases, it's appropriate to do those things initially, but then, or you may not even get a choice because they're taken to the hospital and the eMERGE has already managed them before their wishes were known. But it's important to know that, or I think it's important to have that discussion with your family that if you've been on life support and the prognosis is looking poor for recovery, and in those cases, you need your family to communicate what you would want in that circumstance. So if the chances of recovery are looking poor, it's important to let your family know what you would want in that circumstance. And for most of us, I think that would be to be kept comfortable and to be allowed to die. But you have to picture in that situation, your family member is facing this tragedy where they're losing you, and to now ask them to make a decision for you when they don't know what you want is a very difficult situation. And people often default back to, we should just do everything because I'm not sure. And if that's not what you would want, then it's important to have those discussions.
I'm
Yeah.
about straddling the line between the advanced care directive, which are not eligible except if you're in Quebec, versus not being able to consent. So if you had, are there specific cases where you would recommend, or you could say, yeah, the person, because we're all going to get old and we're all going to die eventually, but I can't put in an advanced care directive that if this is what happens, then I want this outcome. So are there certain cases where you can start the process? You said it can be a couple of years, like a diagnosis of mild heart, like what kind of more mild conditions would allow not an advanced directive, but something that would give you years?
Right. So the question there is about, let me see if I've got it right. So is there, in the case that we're expecting it's going to progress and somebody is going to eventually die, but it's not sort of near at hand, it's not predictable at this point, is that what you mean?
Because if we don't have advanced care directives options in the rest of Canada, yeah, it just seems like, or like the question with the gentleman where you got in an accident, like it's very clear.
Yeah.
The wishes are very clear, but just straddling that line of like, how do you make sure that if people are not gonna be in a state where they'd be happy living, that they have a MAID option.
Right. So I guess the short answer is, if you haven't had 2 assessments by physicians at a time when you are found to meet the criteria, then you can't receive MAID. Yeah. So there's no scenario if somebody can be the strongest advocate and the biggest believer in MAID and be certain they want to have MAID, but if there's no guarantees that they're going to ever be in a situation where they can access that. The reality is that these things often do progress gradually, and if they are catastrophic, like a sudden head injury or a massive stroke, if your family member knows your wishes, those are almost always fatal unless you get life support. So those situations, there's no guarantees of anybody accessing MAID, but in reality, people who are facing those decisions, there usually is an opportunity. With the case of dementia, it is rather complicated, and it does depend on those windows aligning where somebody is, their capabilities have declined, they're suffering intolerably, but they're still capable, and that doesn't always happen. The idea of doing the advanced directives it's extremely complicated to try to predict the various scenarios that can happen because we don't ever really know what our response to illness is going to be until we're in it. Even with something like dementia, somebody might be terrified to death of it, and early in dementia, it's very unsettling, and people are really worried about it. But at some point, they no longer realize they have a problem. And most of us have had some exposure to people with dementia. And sometimes those people are confused and anxious and upset a lot of the time, and it can be difficult to control that. But there's also people who progress to have dementia, and they may no longer recognize who their family members are, but they seem to be quite content and happy in life. They get up and sit by the window, and they greet everyone with a warm smile, but they don't know who anybody is or where they are. And in those cases, that person didn't have the opportunity maybe. But they're also not really the same person that started the journey either. So to sort of make a decision for that person, we can't really do it ahead. Yeah. That said, they are doing it ahead in Quebec, but it's very complicated to set up the parameters where you would want to go ahead with it or not. And the criteria, I don't know the final way that the federal government's going to handle it. But there's always going to be, at the end, the provider is going to be able to assess whether they believe the patient is suffering. And if you may have requested and you might meet all the criteria, but if the provider doesn't believe that you're suffering, they're not going to go ahead. It's worth remembering, too, that the providers are able to make their own decisions. And a provider has never under any obligation to provide a service if they don't feel it meets with their ethics. So maybe that speaks to this idea of finding a provider who agrees with you what you're wanting. But never in Canada can you make a provider do something they don't believe is right. That's another important point. If you did have, certainly there are providers out there who don't believe in MAID and who don't want any part of this. In Ontario, if they're required to make what they call an effective referral, which is to say, if you ask them about MAID and they don't want to provide information and they don't believe it should be an option, they are still obligated to provide a referral, which most of the time just means they should give you the number for the MAID coordinator service and you can get the information that way. But even to that level, if a provider doesn't want to be involved, they don't have to be. Yeah.
The person is accepted for MAID service when they're just beginning an issue. And then they develop dementia and they're not able to give their final consent. Can their family do it for them?
So the question is about if somebody has already been assessed and found to meet the criteria for MAID, and then they go on to develop dementia or confusion. Yeah. So that is a fairly common scenario where people, somebody, for example, who has an advanced cancer and it's spread to their brain, for example. So nobody can ever receive MAID unless they have already consented to it. So you might consent to it and then you've set a date, or maybe you haven't even set a date. You've had the two assessments. You haven't set a date because there's unfinished business. There's people who are trying to travel to see you before you die and that sort of thing. And then, maybe a brain tumor happens and the cancer spreads to the brain and you're no longer able to make the decision. Well, in that case, hopefully you've signed that waiver of final consent that we talked about earlier. So in that case, it's not that a family member is making the decision for them. It's that the patient has made their decision. They've already consented, and they just waived the requirement for that final consent. So that's what that exists for. Yeah. But no, if you're earlier in your illness and you've got for example COPD and you don't meet the criteria now, and then you have something happen, an unexpected brain tumor or something that makes you unable to consent, it's off the table. No one can consent for someone else to have MAID. It's only the patient themselves. Yeah, back again.
Just to clarify that second last question. So if you have a cancer diagnosis and you're undergoing treatment and you have one never knows, of course, but you have an idea of how much longer you live, can you ask for MAID? And then all the dementias are so high risk these days as you get older, and you develop dementia, but your cancer really isn't end stage. You are, because you prepared ahead of time with this cancer diagnosis that is going to kill you.
Right.
You are then okay, even though you're possibly develop dementia before your end stage of your disease, if you know what I mean.
Yeah, okay, I'll try to repeat that back. So you've got a scenario where the patient has a cancer diagnosis. They've initiated the process of being assessed for MAID, and they have or haven't found to meet the criteria at that point.
They know that their cancer will kill them.
Sure.
And suppose depending on the cancer, we can have an estimate of when that might happen with or without treatment.
Mm.
But in the meantime, if you do manage to keep living, but they develop a type of dementia in the meantime, so I guess what I'm trying to say is, should one prepare for me and book it earlier than later?
So the question is, should one prepare for MAID and book it earlier rather than later? I think it's, I understand it's a bit of a funny idea, but I get your point, I think. So I guess the short answer is, if you know that you have a life-limiting illness, so you have cancer, it's stage 4, or your oncologist tells you it's not curable, it's not unreasonable to make connection with a MAID assessor before you meet the criteria. Yeah, and that's often just a bit of a sort of a fact-finding, get to know whether the assessor is a good fit for you, let them get to know your situation, but the reality is you have to meet all the criteria to be deemed eligible before you become incapable. So that's not always guaranteed. So that there's no scenario where you can say, I know this is what I want, and I'm by gosh, I'm going to have it. There's still ways that your health can affect you that you wouldn't receive that. Yeah. Which is why it's so important to, as I say, those advanced care directives are letting your family know what you would want, because that has a very big impact. You could choose not to, of course, choose not to treat your cancer. In extreme situations, you can say, well, if I'm not able to eat for myself, don't feed me, or if I'm not able to drink, then don't give me IV fluids to keep me hydrated. And those ways will lead to death inevitably, of course, as well. And then with, of course, in conjunction with palliative care to make sure that you're kept comfortable. And palliative care, for the most part, is pretty good at keeping people comfortable at the end of life. And when we can't control symptoms any other way, there's an option of palliative sedation, where medications are given to keep the patient asleep until they pass naturally. And that's not the same thing as MAID. That's always been legal. If somebody is unconscious with palliative sedation to control their pain or their anxiety, and we give them pain medications to control their pain, and that hastens their death, that's considered treating their pain. That's not considered medically assisted death. Yeah, so we do, you can think of scenarios that sound pretty scary where you might be in an uncomfortable situation, but I think the planning that should be done, the preparation is that advanced care planning and having a power of attorney in place stating who would make those decisions for you if you're not able to do it, and making sure that person knows what you would want. Yeah, you can never predict all of the different ways that things can go wrong, but you can give them the principles of if in this kind of a scenario, this is what I would want. Yeah, and it's a moving target too, so you have to keep having those discussions. Right now, if you're still enjoying good health, of course you should probably have a full resuscitation. But if now you've developed you've had a heart attack, and now you've got a COPD, and you've got kidney failure and a bunch of other things piling up, it's time to revisit those wishes. Yeah, Paula.
Are you familiar with the goals of care study that's taking place in Huntsville at this time?
Oh, no, I'm not familiar with it.
The goal of care is when the family gets together with the medical team to talk about possible outcomes. There's a lot of data now that can tell you if you have a certain disease, this is what the probability is. It helps you make those decisions on your care at whatever stage you're at. And so it's a bit of AI assisted as well. But it is going on right now in Huntsville, so that's going to be something new. If you are part of a medical team, people are taking care of you. You can talk about goals of care. It is present, but now they're getting more data for it. So.
Yeah, and I believe through hospice in Port Carling, they have goals of care, like facilitation services as well. So you can meet with somebody who can help walk you through the process of what kind of decisions there are to be made. Yeah. Yeah, anytime that, whenever we're talking about prognosis in medicine, it comes up a lot, like, oh, I've been given 6 months to live. That's almost never what the oncologist actually said. What they actually said was that people in your situation on average will live for 6 months, because none of us, doctors can't predict the future. They can just give you an idea based on the particular nature of your disease, what is happening on average or what's expected. But of course, you can be diagnosed with cancer one day and get, have a massive stroke the next, right? Those two are not necessarily related, and they can end your life in a different way. Yeah. Yes.
What if you don't have an immediate family?
So if you don't have an immediate family, that's where a power of attorney really becomes important, a power of attorney document. So in this case, we're talking about the power of attorney for personal care, and you can appoint anybody who you trust as your power of attorney. It's a pretty simple document. So you're really trying to choose the person who you believe would make the decisions you would want. So usually someone who knows you pretty well. Of course, there are people who don't have that either. I look after patients in a group home, and sometimes they have no family members and not really anybody who's capable of making those decisions. And if that's the situation in Ontario, you have the public guardian. So there is an office of the public guardian which appoints somebody. Those people aren't able to make end-of-life decisions. Their default position is to prolong life. So if that's not what you want, you need to find somebody and appoint them. Does that make sense? Yeah. Yeah. I guess the point is it's a good idea to have those discussions with somebody and find somebody who understands your wishes and appoint them.
I understand from something a few years ago that if I choose someone, he or she is not able to inherit any money from me. They can't benefit from my death. When they make a decision to help me die, then they can't benefit.
So the question there is about whether if you're somebody is your power of attorney and making medical decisions for you, can they still benefit from your death? And the answer is yes, those people still can, right? Very often your power of attorney would be your child, and they can certainly be in your will. Now, for choosing for you to die, like a medically assisted death, nobody else can choose that for you. Only you can choose it. But if it's about choosing treatments to prolong your life, then somebody who's a benefactor of your will can make those decisions for you if that's who you choose. Certainly that you can imagine that a scenario could arrive where a family member, or maybe not a family member, a power of attorney is making decisions that the team don't believe is what the patient would actually want. And remember that medical team can make whatever decisions they feel ethically comfortable with. So if they feel someone's not actually representing the patient's wishes, they're not obligated to follow through. You know, that unfortunately that situation is pretty rare. Any other questions?
Thank you very
Great.
much.
Okay. Thank you so much.